I'm excited to be here. I'm always excited to talk about program building. I'm not going to talk about perfusion today. I mean, there are plenty of other people that can talk about perfusion, and I will say that I have tremendous confidence in our colleagues in perfusion, and the evolution of the technologies and the way we think about pediatric perfusion has been quite a story in and of itself. But I thought, because you're all part of programs or will be part of programs, that I would just share with you some of the lessons I've learned, and yes, building and participating in the direction of several programs. This is now essentially the third time I've done that. So we have learned some lessons along the way. Started in Galveston, in the upper left, and Johns Hopkins, Children's Melbourne, Cleveland Clinic, Texas Children's, now Austin, and each place indelibly imprinted me. This was me as an intern way back when at Hopkins. Little did I know what the journey would be for me as a surgeon. I didn't know I was going to be, I didn't even know I was going to be a heart surgeon yet. I thought I was going to be a general pediatric surgeon yet. And turns out I am sort of a pediatric general surgeon in a lot of ways. Anyway, Hopkins indelibly imprinted me. We didn't do pediatric heart surgery well at that time. That's a message to carry along with you. The expectations there were not what they should have been. It's a great institution otherwise. But this was the place that changed me. Royal Children's in Melbourne. This was a humble, austere hospital. When I went there in 1991, thinking I knew something, quickly learning I knew nothing, and had to get my head right about the whole idea of optimizing care for children. And this is a much younger yours truly with my primary mentor, Roger Mee, who was a relentless taskmaster. Why we went there in 1991? Well, there was word on the street, essentially, that what they were doing there was much better than any place else in the world. And in fact, it was. It was so much better that people didn't believe it. They didn't believe, and I can remember some of the disparaging comments that were made about, oh, they're fabricating the results, et cetera. Well, they weren't. And that started a playbook, and I still have that playbook to this day, 30 years and counting, which we're constantly refining, and that work will never end. Dr. Mee was the subject of a book. If you haven't read it, it's worth reading, Walks on Water, written by Michael Ruhlman. Michael went to the Cleveland Clinic and embedded himself in their unit for a year, and literally was there constantly learning about what separates a dedicated pediatric heart unit from the rest of the pack. And it's quite a riveting story. And Dr. Mee, fortunately, was ultimately at least acknowledged in his home country of Australia, where he was honored with the Order of Australia, which is essentially being knighted. And that was quite a big moment for Dr. Mee. We got started at Texas Children's way back in 1995. It was rough going. It was rough going back then. And some of you all here were around at that point, but we learned a lot along the way, and I'm proud of what we accomplished. But then we had a new opportunity in Austin, and Austin has been an enigma. Austin, the great University of Texas, didn't have a medical school, and that was a big deficiency. Austin's a great, giant, growing city. I'm told that Austin now is #2 in the state of Texas and soon to be #1 in vertical feet in buildings. It's incredible what's happened there, but imagine that city didn't have a medical school. But how did we get there? It's been a strange story. This is one of my favorite quotes. If you haven't read this book, read it. A gentleman in Moscow, he said that our lives are steered by uncertainties, many of which are disruptive or even daunting. But if we persevere and remain generous of heart, we may be granted a moment of lucidity, a moment in which all that has happened to us suddenly comes into focus as a necessary course of events, even as we find ourselves on the threshold of the life we have been meant to lead all along. That's the way many of us feel about where we are right now in Austin. It's a very special time to be there, where there's a new vision in medical education. The idea of creating a new sort of doctor, that subject is undebatable. Medicine needs to be refreshed constantly. That opinion is certainly not unique to me. We're very proud of our Dell medical students. We're very proud of our hospital where we work. We're the primary teaching hospital for University of Texas Dell Medical School in pediatrics. And of course, these are our constituents. And the question always is, what are our expectations? What are our expectations for children with heart disease? So some of my observations along the course of time about high-performing centers. First of all, it's always about the people. It's always about the people. You can have the nicest facilities, the nicest gadgets, but if you don't have the right people and you don't have people that are completely committed, typically completely dedicated individuals, then it's hard to perform optimally. So excellence begets excellence. One team, one team, one team. The phenotype and probably the genotype of these people is that they're relentless and want to be leaders, not followers. What about the vision of the institution? Always putting patients first. Now, a lot of places say that. A lot of places say, you see it on billboards, you see it in magazines, you see it in news articles, but do you really put the patient first always? In my experience, humility is palpable in the very best units. Service is paramount, and the enterprise transcends individuals. All of this is easily said. It's not easily achieved. So our programmatic rationale was that this is a complex subject. There's significant variability in the subject. That's very well demonstrated in the peer-reviewed literature. Patient experience is highly variable. Anyone who's been a patient would tell you that being a patient in this modern era is extremely difficult. We have disjointed, fractionated healthcare. So based on our collective experience, we felt that we had an opportunity to develop a new sort of integrated program focused on patients and families. So that was the inception of what we now call the Texas Center for Pediatric and Congenital Heart Disease, which we started on September 1st of 2018. The idea is to redesign the congenital heart disease journey in a holistic manner. So our foundational principles include a horizontal leadership structure, basically a very inclusive leadership structure, financial transparency, clinical performance transparency, longitudinal care coordination, integration of facilities, and rapid cycle and performance improvement. Now, again, all great words, not easily achieved. And then what about the focus on the family? Focus in a novel way on critical psychosocial issues that the families face, that the patients face. Interdisciplinary patient and family consultation, long-term follow-up, integrating families in an advisory council, educational classes, and a lot of familial social events. So as I said, we got started on September 1st, 2018. Today, we've hired over 400 FTEs in the ensuing 5 years, so we've been busy. The names on this organizational structure won't mean anything to you, nor should they, but the point is inclusivity and leadership. Everyone has a place at the table, and we see each other a lot. We're conference heavy. We meet every morning and most afternoons, and we see each other a lot. This is our leadership team. Be at that table: cardiology, intensive care, nursing, chief medical officer, outcomes, advanced practice nursing, administration, anesthesiology. Everybody has a vote in what we do, but this is really the most gratifying thing about the way we work. This is every morning at 7 o'clock, where every single patient in the heart program is reviewed by the entirety of the heart center every day. Yesterday, we reviewed 54 inpatients. Soup to nuts. It took us a couple of hours, but this we feel is paramount in keeping everybody focused and moving the children forward. And then we end the week, just as we've done for 30 years. Every Friday morning at 6:15, we review every patient from the preceding week, and this is sort of a no holds barred review of our performance and what we could have done better. And again, it's all about the people. central to our vision is measurement. And the question is what to measure and what to do with the information. So Dr. Mary, my very capable colleague, came up with the idea of a unit called the Health Transformation and Design Program. Take information, design solutions, and transform care. And so we're on a journey of identifying meaningful outcomes. Of course, a lot of people tell us what we should measure, but that doesn't always get us the whole story. We want to know what families want us to measure. We want to know what individual patients want us to measure. And we're going to continue to refine that, expand on that a little bit. But those efforts generate a lot of academic opportunity. And since we started the program, we've had 129 peer-reviewed publications as of yesterday. Of course, this is an academic health center. This is our current research fellow, Matthew Mikulski, going into general pediatric surgery. And he's been a tremendous resident in our program and involved not only in clinical care, but he achieved a master's in healthcare transformation from the Value Institute at the University of Texas, Austin, and really a terrific member of our team. We've performed just short of 1,700 cases since we got started. We've gotten busier and busier each year. We're happy that the results, as we expected they would be, have gotten better and better. This is the 5 years prior to our program inception. And then since we started an overall mortality of 1.5%, this was not surprising to us. We believe there's other work to be done to really move the field forward, but we are transparent about our outcomes. This is a program data sheet that is generated in our program each month, and it is sent to everyone in the program, certainly any family referring doctor that wants to see how we're performing can get this information. Of course, we do the same thing in the intensive care unit, comparing ourselves to our peers, as many places do. A little bit about our performance metrics these days. There's a lot said about this, and there's something going on. And it's a little bit beyond the scope of this conversation today, but think on how we're measured as programs. Of course, the Society of Thoracic Surgeons is essentially the most influential body when it comes to surgical outcomes in heart surgery. And a program is meant to compare itself to our peers. And so the observed to expected outcomes, just like here in the Texas Heart Institute. How are we performing each year? When we arrived in Austin in 2018, it wasn't a happy story. So this is 4 years rolling aggregate data. The program was performing at a 1-star rating. That means performance 2 standard deviations worse than our peers in terms of expected outcomes. Within a year, we had changed that to a 2-star rating, meaning within 2 standard deviations of our peers, observed over expected. And then just last data harvest, we've become a 3-star program. Again, not surprising to us. This is something we've done before, focusing on the patients holistically. But the real question is, how do we move the needle on measuring what matters most to patients and families? And that's where we're just getting started. So this was a monumental day for me. This was about September of 2018. This young woman showed up. Actually, she contacted my assistant and said, I'm here in Austin. I'm from Los Angeles. I want to meet Dr. Fraser. And the question was, why? And she said, well, he operated on me when I was 3 weeks old. So this is Isabel. Isabel was a graduate student in screenwriting at University of Southern California. I remember her well. She had transposition VSD, arch hypoplasia, left juxtaposition of the atrial appendage, type D coronary arteries. We did a switch VSD closure arch repair when she was 3 weeks old, and I hadn't seen her for 26 years. So her question was, what happened? Let me tell you about my journey in life, and more importantly, let me tell you about the journey of my mother. And it was a sobering journey that Isabel shared with us. And so that catalyzed some thinking. What do we know about the journey of patients and families with congenital heart disease. We don't know that much. We don't know that much. We know sound bites. We know little iterations of information. We know it's hard, but we don't put it all together. Now, about hard. It's about hard. So here we are in the Texas Medical Center. I'm sure Dr. Cooley would be very happy for me to talk about Dr. DeBakey here. I mean that sincerely. We're here in the Texas Medical Center, the home of people who chased hard problems. Think about this. This is textbook of congenital heart disease, 1967. The authors long since gone, but famous individuals focused on difficult problems like hypoplastic left heart syndrome. Dr. Cooley and Dr. Hallman's book, same era, hypoplastic left heart syndrome. Bad, common. The prognosis is hopeless. The prognosis is hopeless. There is no effective treatment. Now, this was when I was a little kid. This is when I was a little kid. That's what was written in the literature. So what are we doing today? What problems do we need to address? Just like happened multiple decades ago. It's an interesting dilemma that we face because we're focused on measuring. We're focused on our numbers. Are we chasing the most difficult problems? I'm not so sure we are. And that's been our experience in Austin. It's been very interesting, very interesting. We get referred a lot of patients that no one wants to take care of. Why is that? It's curious, isn't it? And they come from a lot of places. Turned down, down by other centers. This is a child with trisomy 18, turned down. Family desperate. Yes, we'll take care of them. How about this young woman? Turned down. She has a mucopolysaccharide storage disease, severe aortic stenosis, severe mitral stenosis. Unfortunately, she's 4 feet tall and her cervical spine is fused, her chin is on her chest. She's dying at home, turned down. What would Dr. DeBakey and Cooley have us do? They would have us take care of her. So she had an awake fiber optic intubation. Dr. Gottlieb is going to talk a little bit about this subject in a minute. That was quite an adventure. Here she is. This is a video laryngoscopy as she's talking and being intubated. Why? Because it's a very unsafe airway. And long story short, she was able to be successfully intubated, which frankly was the most difficult part of her care, was her airway management. And we successfully repaired her aortic valve and replaced her mitral valve. Or this child who was sent to us with an end-stage failing Fontan circulation, who arrested, who had 2 hours of CPR, was placed on cervical VA ECMO, and she woke up awake, no heart function. So what do? Well, we had to become creative. Richard and I, fortunately having worked together for a long time, knew how to put VADs in. We put an HVAD in her. This was the first. There was no VAD program at Dell Children's Hospital. So we needed to get it started to take care of her. She went home. She had a rough journey. She got transplanted and is doing well. Or this child, 800-gram transposition VSD, 800 grams, 26 weeks gestation. Whole family told that there was nothing that could be offered, and take your baby's going to die. And by the way, the mother had another child die. That was a preterm delivery. We thought differently. So here's Dr. Gottlieb organizing a strategy session to take care of this little baby. There's yours truly taking care of her in the operating room. This is the second sub 900-gram arterial switch that we've done, and it turns out it's the same team that's done it twice. And she did very well. She had a lot of premature babies, things to deal with going home. Eventually was discharged, and she's back in her hometown with her mom. Or this one who came from another state. This one who was languishing in a unit in another state. It's a single ventricle ectopia cordis. It's a weird ectopia cordis. I haven't seen one like this, where essentially the heart is coming out the omphalocele. But this baby was just left to die. And we were able to palliate her, and she's kind of helping herself with her own heart there. That was kind of one I haven't seen before. This baby also sent home. Imagine this. So this was a baby that had prenatal diagnosis of ectopia cordis, pentalogy of Cantrell to be exact. So it's tetralogy with an ectopic heart. This mother was advised to deliver the baby vaginally. That's remarkable that that was the advice that she was given. She did deliver the baby vaginally. Amazingly, the heart didn't rupture. And then she was told, take the baby home. Now, when you take the baby home like this, what does the baby die of? Infection. It's an abomination. So they asked, could we take care of her? And the answer was yes. So we took this baby to the operating room. The expectation that we could get this heart back somehow covered was an interesting one. You see the apex pointed straight north, and we were able to read it. The baby was about a week old. Came to us. So we were able to raise myocutaneous flaps on either side, get the heart covered, and that was an interesting thing. We put allograft skin over the heart. It's essentially a collagen matrix, and the epidermis has grown right over it. It's really quite remarkable. The child's coming along fine. Next. There's that alloderm. That's about 2 weeks post-op, and you can see the skin starting to grow over it gradually. And eventually we'll repair the tetralogy lesion. The patient's relatively well balanced at this point. Next. We've offered heart transplants to patients that were turned down elsewhere. Next. This was one who was our first ABO incompatible heart transplant. She's doing well. Next. Talked about the VADs. There's a whole population of patients out there failing Fontans. Certainly we had experience with this at Texas Children's, and now we've had experience with these children in Austin. They have no place to go. They have no place to go. Their circulations are disastrous, and hopefully there'll be better solutions on the horizon, but we've got several patients that we've successfully supported single ventricles with VADs. Next. And then some that we've been able to resuscitate the heart. This was one that came in with a tachycardia-induced cardiomyopathy. We supported her for several months and eventually explanted the Berlin heart. Next. Now, I can't be here in Dr. Cooley's house and not again emphasize the subject that I was talking about. And for the rest of my career, I'm going to speak vigorously about this. Our job is to move the needle. Never did I hear from Dr. Cooley inoperable. See Dr. Fraser there. He might affirm that. Never did I hear from Dr. Cooley inoperable. What I heard from Dr. Cooley was, we'll do our best. We'll find solutions. Imagine if Dr. Cooley and Dr. DeBakey had said thoracoabdominal aneurysms were inoperable. Imagine if Bill Norwood had said hypoplastic left heart syndrome is inoperable. The numbers of patients that come to us these days who have been deemed inoperable is shocking. Next. So back to Dr. Cooley. What a great idea he had 60 years ago to integrate all things cardiac. Well, that sort of dissipated eventually. We're trying to recapitulate a similar structure in Austin where all things cardiac are working together, and we have a new institute, the Institute of Cardiovascular Health, where the adult and the congenital programs are more effectively integrated. We think this is very important, and we think that the backbone of the university provides a very special opportunity. Next. So this is the current leadership of that. Next. And we're really pleased that we have a new chief of adult cardiac surgery, George Arnatakis, John Hopkins trained. Penn trained aortic surgeon. He is a tremendous adult leader, very busy already. Next, working with my very capable, this is a funny story. I'm checking out at Central Market and I looked there and there's an Austin magazine. I said, oh, I know that guy. That's my partner, Dr. Mary, who made the cover. Tremendous leader. Next. And we're off to the races. So I'll just leave you with some things that I've learned along the way, because all of you have influence in operating rooms. Now, most of you are not surgeons, but these principles all apply to all of us in the operating room. So this is my evolving, you've heard of Robert's Rule of Order, which apparently doesn't get followed very much anymore, but nonetheless, these are my ideas about how an operating room should run. First of all, you can't be too gentle and you can't be too accurate. If you're too fast, you're going to have a bloody operation. You're going to be bloody in, you'll be bloody coming out. If you hurry in the operating room, you, and most importantly, the patient, will pay for it later, usually in the ICU or elsewhere. There's only one place for every stitch. That means measure, measure, measure. Hold is your friend. I believe that very strongly on bypass. It's your friend. The pump is your friend if you know how to use it. The worst thing for the heart, the very worst thing for any heart, is distension. Distension is a killer. I don't really care what mode of protection you use, because I don't really frankly think it matters. But if you get the heart distended, you're going to have a sick heart. Measure, 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 then cut. Consider what ifs way in advance. The best time to de-air the heart is when the cross clamp is on. Next. Redo operations, open laterally into both pleural spaces, take your time, keep dry, have high expectations of a successful reentry, no matter how many previous sternotomies. I don't know how many patients have come to us, 5th sternotomy, 6th sternotomy, inoperable. Not true, not true. There are solutions to be found. It's up to us to find the solutions. The most challenging reality in pediatric cardiac surgery is where to set the expectations. I've learned this over and over and over again. Back to Dr. Cooley, back to Dr. DeBakey. What if their expectations had been low? Imagine the decades and the lives that have been set back. This is a big one. Keep the OR quiet. All of you as perfusionists have influence on this. Keep the OR quiet. Why? Because there's information that is going on in the operating room, the tone of the pulse ox, the cadence of the rhythm, and the surgeon has to be in control of the room. When the surgeon loses control of the room, bad things happen. Now, I'm a big believer, as the people that work with me will attest, of clear, unambiguous feedback communication. Protamine, protamine. Pump on, pump on. Heparin, heparin. Lives have been saved because of that. What separates great pediatric heart surgeons, in my estimation, is tenacity. If the operation doesn't look good, it's probably not good. There are no mysteries in outcome. The only mystery is that we can't find our way to figure out the solution. And it's a very slippery slope when we start blaming our patients for poor outcome. Our job is to find the solutions, and we can't be timid. There's no such thing as a timid, successful pediatric heart surgeon. And then focusing on the details. I say it over and over to the people that I train: aim small, miss small. Aim small, miss small, and be gentle. Next. So we have a long way to go. We have a lot of work to do. You all have a lot of work to do. Aim high. Keep pushing, just like Dr. Cooley did, just like Dr. DeBakey did, just like Dr. Nee did. Push hard. Always keep setting the bar higher and higher. Thank you very much.